We have great pleasure in welcoming you all. I am Dr. T.S. Chandrasekhar. Good evening. I am Dr. T.S. Chandrasekhar, American College of Gastroenterology Governor, India region. I represent as member Scientific Committee of World Gastroenterology Organization, and I bring warm greetings from the Tamil Nadu Dr. MGR Medical University as the honorary distinct professor, and from my center, Med India Hospital and Academy. The earlier two seasons of our webinars, we saw the participation of over 9,000 delegates from all over the world. That really inspired us with the help of MicroLab. Why don't we have the third series on gastroenterology? This time we will name the topic, the world experts are here. And this is what we did it. And with the catchy name New Endo G webinar series that became a great news, it has been endorsed by the American College of Gastroenterology. The first webinar of the series 3 was inaugurated by Professor Jonathan Lighton, President of American College of Gastroenterology in the month of April. And we saw the great stalwarts participating in our field. And one of them, I just want to recall, in September, we had a Nobel Prize winner, Professor Barry Marshall, the discoverer of Helicobacter pylori. He spoke on the journey of discovery of Helicobacter pylori, and further that really inspired thousands of delegates from all over the world. That really inspired, because these webinars were possible with the help of my colleague, Dr. Gokul Satyamurthy, Raja Yogesh, and Prasad, and Dr. Trinyana Sambandam. And what we designed our webinar to reach to the wider audience, we have several ambassadors from each one representing one state of our country, that is from Dr. Chaubal, Praveen Roy, and Ramesh Kumar, Srinivas Rao, Praveen Kumar, Arvind Gubbi, Greece, Mohapatra, Ashish, Nirmaljit from Punjab, and Rajiv from Maharashtra. That really clicked very well. Dr. Lamba from New Delhi, and Goswami from Northeast, Ashish Kumar, and Arvind. And we thought of why not we reach out to the international scenario. So we had international ambassadors from USA, Malaysia, Nepal, and Bangladesh. They have been very helpful in propagating the message of our webinar. And we have really designed 12 webinars scheduled from April 24 to March 25. And we are going to continue next year. Also, we had a various topic, a wide-ranging topic from celiac disease to hepatology this time. And we have a very interesting topic, colonoscopy and ERCP, fecal microbiota, and high-quality colonoscopy and H. pylori infection, GA malignancy, and so on. And we got really enthused by the CME credit hours from the Tamil Nadu Medical Council, and other state the members also can take advantage of using this credit hours. And these webinars would not have been possible without the academic partner, MicroLabs, and they called Micro Knowledge Academy. And today is going to be a great day on hepatology, because we have two important speakers, and the topic, muscle to MASH, how the terminology has changed, and cirrhosis to HCC. And we know the natural history, how it is progressing, how we can arrest the progression. This is going to be by Dr. Professor Ajay D'Souza, and it is going to be moderated by Professor R.K. Dhiman. And this is the director. I will introduce one by one, and Professor Sarin is going to talk on non-invasive assessment of liver fibrosis and portal hypertension, and ability to be moderated by Professor Ramesh. And it's my pleasant duty to introduce here the first speaker, Professor Ajay D'Souza, Professor Head, Department of Hepatology, PGIM at Chandigarh. He is the Secretary General, Indian National Association for the Liver Study, and he has been the recipient of several awards, national convener of the task force on non-alcoholic fatty liver disease. That time, now the terminology has changed, and he is the recipient of the Professor Datta Memorial, the Dharamveer Datta Memorial Oration Award, and he is an associate editor of Journal of Clinical and Experimental Hepatology, and his H index is 57. So you cannot have a better person because he had done the original work. And the first moderator, Professor Dhiman. He is the director of Sanjay Gandhi Postgraduate Institute of Medical Sciences, SGPGM, Lucknow. He established India's first DM program in hepatology at PGI Chandigarh and launched the National Viral Hepatitis Control Program in India. His H index is 65. And I remember I have met the Harold Khan when he came to Jaipur. I remember vaguely that one of the ISG meeting, he is the one who described spontaneous the bacterial peritonitis, SBP, and he has got the award from the American Association for Study of the Liver. Apart from Viceroy Award, he recently received Padma Shri also. I will welcome Dr. Dhiman. And Shivakumar Sarini is known all over the world, and he is the director of Institute of Liver and Biliary Cells in New Delhi, president of National Academy of Medical Sciences, honorary professor Jawaharlal Nehru Center for Advanced Scientific Research. He is the chairman board of governors Medical Council of India. Now it's that time 2010 chief editor Hepatology International. His H index is 116, and he's a Padam Bhushan awardee, and he's a IFP Antia Lifetime Achievement Award. And my friend Dr. G.N. Ramesh is a senior medical gastroenterologist from Astos Hospital, Kochi, the founder convener of Cochin Gut Club, one of the prestigious club in doing a lot of GI work in this part of the country. Academy program member, DNB and postgraduate courses. He is a fellow of the Society of GI Endoscopy, the past president of SGI, and his fields are. He's got wide interest in various fields apart from hepatology and inflammatory bowel disease. We have very good panelists, expert, Professor Anil Arora from Sir Gangaram Hospital, New Delhi, Professor Epan from CMC Vellore, Dr. Goswami from Dispur Hospital, Guwahati, and Dr. Murugan from Apollo Hospital, Chennai. And my pleasant task is to introduce the topic and the faculty. Now I hand over the mic to Professor Dhiman. Now the lecture is going to be started now, and he will introduce the topic, how important it is. Then he'll invite the first speaker, Rajay, to start the proceeding. Okay.
Thank you, Dr. Chandrasekhar. The first talk is Method to the MASH and Cirrhosis to HCC Natural History and Arresting the Progression. The method nowadays, the recent nomenclature, and is very important because it is fast catching to be the number one, the slot for the end-stage liver disease. Number of the liver transplantations because of the end-stage liver disease, because of the method, is alarmingly increasing. Therefore, we have to look after this entity, and most importantly, as the topic says, how to arrest the progression also. Now I will hand over to Dr. Ajay D'Souza for giving the talk also. Thank you.
Thank you, sir, and good evening, everyone. So at the outset, my sincere thanks to Dr. T.S. Chandrasekhar, his whole team of Med India, and the ACG for giving me this opportunity to be part of this very important webinar this evening. Thank you so much. And again, my sincere thanks, and extremely sorry for this technical glitch, everybody, the whole audience. And again, my sincere thanks to Dr. T.S. Chandrasekhar, his whole team, and the ACG for this, kind of, invitation for this webinar, very important webinar, I must say. And I bring greetings to all of you from PGI Chandigarh and also from the Indian National Association for Study of the Liver. The topic I have been assigned is to take you through the natural history of MASL D, which was earlier called NAFL D, and MASH, and earlier called NASH. So now let me just spend maybe initially 3-4 minutes on this nomenclature change, because I did find there were some questions related to that. So this entity, NAFLD, we knew it for last many years now, but then in between, there was some suggestion about this change of this nomenclature from NAFL to MAFLD. But finally, in 2023, there was a Delphi consensus which happened, and the lead was taken by two major societies globally, which was ASLD and EASL, and finally it was joined by various other societies, including INASL. And this change in nomenclature happened, and this is because of various reasons. And I'll not get into the details, but world over now, globally, NAFLD has been replaced by MASLD. And this is because this is so closely associated with metabolic dysfunction. Uh, Again, to make the diagnosis of MASLD, what you require is that you just have to document hepatic steatosis on any kind of imaging, or maybe on histology, and then you need to have 1 out of 5 metabolic risk factors. So anybody who has that becomes MASLD. Now this is a positive diagnosis. Earlier NAFLD used to be a diagnosis of exclusion. And now the MASLD can coexist with various other etiologies. For example, even if you are taking alcohol, small amount of alcohol, which, moderate amount of alcohol, you can still call it as, still be MASLD, but then the nomenclature which has been now given to that small amount of alcohol with metabolic dysfunction and steatosis is MET-ALD. So to cut it short, if somebody is taking alcohol, which is, say, a female less than 20 grams a day, or a male less than 30 grams a day, and has hepatic steatosis, and also has a metabolic dysfunction, is MASLD. Anybody who's taking alcohol between, say, 20 to 50 grams per day for females and 30 to 60 for males, and also has hepatic steatosis and metabolic dysfunction, that has been labeled now as MET-ALD. Any amount of alcohol which is more than that, that is, say, more than, say, 60 grams per day for males and 50 grams per day for females, actually becomes alcohol-related liver disease. These patients with alcohol-related liver disease can also have metabolic dysfunction, but then they are not called MET-ALD. Then we call them as ALD with metabolic dysfunction. We can have more discussion on this maybe at the time of the discussion session. But let me move on to say that, can we go on to the next slide, that this nomenclature, as I said, has now been endorsed globally by various societies. And if you can see in between here, the INASL also figures here that of all the various societies, INASL has also endorsed this change in nomenclature, and henceforth I'll be Can you go to the next slide? When this change in nomenclature happened, the first apprehension which came into the minds of a lot of people was that what will happen to the whole research which has been carried out by the name of NAFLD for last 30-40 years. What will happen to that, and do we need to do it everything again, which means maybe the diagnosis, the prognosis, the treatment, and everything. So then people started looking at that. What are the similarities and differences between the MASLD and the NAFLD? And then again, there were lots of papers which came in, and we have a consortium in India called the Indian Consortium on NAFLD, earlier ICON-D, and now we call it as Indian Consortium on MASLD, ICOM-D. So we also, kind of analyzed our data. This is around 7,000 patient data of fatty liver disease. And what we showed was that there was around 98% similarity between MASLD and NAFLD. So which means you don't need to worry. You don't need to bother. You don't need to carry out all this research again. The previous called NAFLD is almost similar to MASLD. So in this talk also, henceforth, I'll be using both the terminologies, interchangeably, which means MASLD and the NAFLD. Can we go on to the next slide? So, NAFLD or MASLD is a kind of, is a pandemic now. I think this is such a prevalent disease globally. So I'll not get into the global data, but then if you look at the Indian data, which we had, compiled, 3 years back, me and my colleague, and if you look at the prevalence in the country, especially in the northern part of the country, at least in Chandigarh, this was 53%, which means every second person was found to have fatty liver. If you look at again in some parts of the Kerala, the prevalence is close to around 50%. So which means, it is a disease which has a high prevalence, but it is variable. There are certain geographical differences between especially rural and urban areas. And again, if you look at the Calcutta, I think this was one study from rural part of the country where it was found to be, a lower prevalence. But then, can we go to next slide? If you just press it, this will come out to show it. Recently, there was a systematic review and a meta-analysis of all these studies which have been done for the prevalence in this country. And this was led by Dr. Sharma from AIMS. And then if you look at the prevalence in India is close to around 38.6% in adults and maybe in 35% in children, which is, even if you compare it with the global prevalence of fatty liver disease, this is much higher. The global prevalence is thought to be close to around 30%. Next slide, please. No, but the issue is that all patients with fatty liver disease are not same. Fatty liver disease or MASLD or NAFLD is a spectrum which can range from just fat in the liver, so-called just NMASL or NAFL or simple steatosis, or it can have some inflammation and fibrosis, and then we call it as NASH or MASH, and then they can get into cirrhosis and even liver cancer. So it is a spectrum. Now, so what is the prevalence of this spectrum? I think I'll show you some data on this, but what we are discussing today is that what determines the natural history, which means that how these patients go from one stage to the other, say from a stage of only steatosis to MASH, to cirrhosis and to liver cancers, what determines this and how can we kind of arrest or progress that? And we go on to the next slide. So now what I'm going to show you is to show you some of these, slides which tells us about the natural history of this disease, MASLD. In general, this is a slowly progressive disease. And if you look at this diagram and this cartoon here, this tells you that this may take even 15 to 20 years for a patient of MASLD to progress onto a disease with high fibrosis so as to have the liver related, outcomes or liver related events. And this may depend upon the kind of the stage the patient initially comes to you. If somebody comes to you at a stage where it is F0, which means no fibrosis in the liver and just has fat in the liver, it may even take 20, 30 years for that patient to get into a stage of F4. And similarly, if you detect these patients at a stage of F2, it may take lesser, say 15, 20 years. And similarly, if you detect these patients at F3, then obviously the progression is a little faster. So it depends that what stage the patient comes to you. The natural history obviously is dependent on that. But other important thing is that if you look at this diagram here, this also tells you that at all stages, the disease can progress, but this can also regress, which means that depending upon the risk factors, which we will discuss further, the disease can progress and it can regress and it can take an either way. And again, I think, as I said, we will discuss all these factors. Can we go to the next slide? And in the next slide, this simplifies the same thing and it tells you that what are the risk of progression from one stage to the other, which means that from healthy liver to the MASL, we know that, around 30% or 35%, as I said, will have fatty liver. Of these, around 15 to 40% of these patients will progress on to have MASH or NASH. And then they can progress on to early fibrosis, and later around 10 to 15% can even progress on to advanced fibrosis or cirrhosis. But then again, one thing again we need to understand is that everybody does not progress at the same pace, which means there are certain majority of the patient, as I said, it's a slowly progressive disease, and majority of the patients are called the slow progressors, 80%. But 20% of the patients, they progress very fast. So they are known as rapid progressors. So I think this is very important to identify that who's progressing at what pace and whether he's progressing, regressing. And again, as I said, we will get into the risk factors which determine all this. But before that, next slide, please. all these two diagrams which I showed you about the progression is based on certain data. And again, I think the time will not permit me to get into all the studies, but I'll just summarize by showing you one or two studies or maybe systematic review and the meta-analysis. This is one of the largest studies from Mayo Clinic led by Alina from there, more than 5,000 patients of NAFLD. And if you look at this, again, I think this took them almost 15 years to move from the stage of NAFLD to significant fibrosis or advanced fibrosis or compensated cirrhosis. And that also happened in only around 3% of the patients, right? But then once they are advanced fibrosis or cirrhosis, then your risk of progression on to decompensation is high. Maybe 1/3 of them will have decompensation. Once you have had more than one decompensation, your risk of further decompensation further goes up. So, again, can we go to the next slide? And all this data, and as I said, more these studies, they were again summarized in this particular systematic review and meta-analysis. Again, close to 10,000 articles which were screened. Finally, 54 studies were more than 25,000 patients were included in this meta-analysis. And this also tells you that at various stages of fatty liver disease, you can either progress or regress. Next slide. And again, the progression and regression would depend upon that what stage the patient comes to you. If the patient comes to you, obviously at the stage of NASH and with fibrosis, obviously they are at a higher risk of progression. But similarly, as I said, they can still regress depending upon how good do you control their metabolic risk factors and all the risk factors which are responsible for the disease. Next slide. And the most common quoted study which looked at the progression of these patients is this study. This study looked at again close to around 11 studies, around 400 patients, all biopsy proven patients with NAFLD. And then they had around 1/3 of them had fibrosis progression. Again, if you look at this, around 20% of them did have improvement in their fibrosis stage also. So finally, what the message this study gave is that it depends upon that what stage you initially come in. Those who came at a stage of NAFL, which means only steatosis, for them, the progression by one stage of fibrosis occurred over a period of 14 years. Whereas, if you come at a stage of NASH, then one stage of progression can happen in maybe just 7 years. So I think that initial basic disease, when are you detecting this patient, is very, very important. Next slide, please. So here what I've done is I have summarized, as I said, that what determines the natural history of patient with MASLD. As I said, as I was emphasizing, that baseline disease is very, very important. Whether you detect them when they just have fatty liver, or when you detect them when they have MASH, or when they have MASH with fibrosis, or when they are already cirrhotic. Other than that, your baseline disease, there are other factors. For example, I'll show you some data. Ongoing inflammation is very, very important. If somebody has ongoing inflammation in the liver, that is the driver for progression, and that's the driver for fibrosis, and ferritin is a surrogate marker for that. Similarly, the presence of the number of metabolic risk factors, somebody is taking alcohol or not, even in safe amount of alcohol, and whether somebody has gene variants which are so closely associated with fatty liver disease. Now I'll show you some data on these. Maybe we can go to the next slide. So the next slide again, this is a very recent study, which is actually based on the levels of ferritin, and they divided them into whether they have low or high level ferritin. Why they have chosen ferritin? Ferritin is a biomarker again for hepatic inflammation. There's something, an entity called dysmetabolic iron overload syndrome. This is a very common, I think, if you practice hepatology and if you look at these patients of fatty liver disease, many of these patients will come to you that they have elevated ferritin. But when you look at their percent transferrin saturation, that is, they are normal. So they do not have really iron overload. So ferritin here is a marker of ongoing necroinflammation in the liver. And this particular study also told us that if you have a high ferritin level, which indirectly tells you that there's an ongoing necroinflammation, your risk of having liver-related events is much higher in these patients in comparison to those who have lower ferritin levels. Can we go to the next slide? So again, in this slide, as I said, it depends on that what stage of disease you come in. And this is a very elegant study which was led by Professor Sanyal. This is again a CRN study, which is again close to around 1,700 patients. And in this particular study, what they said was that if they divided this, around 70% of the patients did not have fibrosis. And this is maybe true in our clinical practice also, that majority of the patients who will come to you may not have much of inflammation or fibrosis. They may just be just nephral or may just have minimal inflammation. So what they did was they looked at these patients prospectively. Next slide. And what they showed in this particular study was, next slide, and what they showed was that it was the stage of the fibrosis which was the major determinant of progression of this disease, which means that with increasing fibrosis, it was associated with all the complications of liver disease, may it be decompensation, may it be, all-cause mortality, may it be even occurrence of extrahepatic events. For example, we know that these patients can, on long term, can develop type 2 diabetes mellitus. They can have chronic kidney disease. So all that is dependent on the baseline fibrosis. So fibrosis is a very important determinant. But as I said, fibrosis is determined by ongoing inflammation. So they go hand in hand. So if somebody has active inflammation, somebody has, increasing fibrosis, obviously the outcome, and this particular study told us that yes, your liver related event will happen much more commonly with increasing fibrosis. Next slide. And on the same lines, as I said, we have this consortium in India called ICON-D. We had analyzed our own data. This is, now we have close to 10,000 patients in this consortium, but this was the time when we had analyzed around 4,000 patients. And then this study also, we divided these patients into, based on FibroScan, whether they have significant fibrosis and whether they have, cackled or compensated advanced chronic liver disease based on their LSM. And next slide. And what we showed, because since we are discussing the natural history and the outcome, next slide, what we showed was that ultimately, when we looked at the liver related events, next slide, and the extrahepatic events, all were happening much more commonly with increasing fibrosis, which means whether these were liver related events, occurrence of jaundice, occurrence of liver cancer, occurrence of ascites, or whether they were extrahepatic events like occurrence of cardiovascular events, occurrence of CKG, occurrence of fractures, and all that, they were all happening with increasing fibrosis. So I think so the baseline disease, as I said, is very, very important in determining your clinical outcome. Next slide. So as I said, then comes, other than the baseline disease, what are the other important factors which will determine the natural history? The other important is the number of the metabolic risk factors. More the metabolic risk factors, more is your risk of having NASH, more is your risk of having fibrosis. And this particular study, again from Baylor Medical College, again led by Dr. Fasiya Kamal, showed us that if you have more number of metabolic risk factors, your risk of having cirrhosis and risk of having liver cancer is much higher than somebody who does not have these metabolic risk factors or has lesser metabolic risk factors. So the number of metabolic risk factors are very, very important. Next slide, please. And these metabolic risk factors are also very important in determining the liver cancer even without cirrhosis. So we know that around 80-90% of all our patients with liver cancer will have underlying cirrhosis, but 10-15% of these patients can have HCC, without cirrhosis. And within those non-cirrhotic HCC, NAFLD or MASLD is a major reason. I think we had analyzed our data, and what we had shown that of all the non-cirrhotic HCC, 50% of patients are related to MASLD. And what determines the liver cancer in this cohort of non-cirrhotic HCC is nothing but the metabolic syndrome. More the number of metabolic risk factors, more is your risk of HCC. Next slide, please. So other than the basic disease, now the question comes is that if metabolic risk factors are so very important, what is the outcome in those who do not have metabolic risk factors still have fatty liver disease? We know of this entity called lean NAFLD, or those who are not overweight or not obese and still have fatty liver disease, what happens to them? So there is a little, controversial data. This was one such study. Please continue to click. Next slide. And this particular study actually had shown us that the overall, the disease was milder in the lean group in comparison to the obese group, whether it was related to the liver related events or whether it was related to the extrahepatic events. Next slide, please. I think this was all lesser in the lean group in comparison to the obese group. Next slide, please. But then, So as I said, even they looked at all the extrahepatic events, cardiovascular events, everything was happening lesser in the lean group. Next slide, please. But then, as I said, we have a controversial data. There was another study which actually said that yes, there is no difference between the lean and obese NAFLD. But when they looked at the overall, over a period of time, what was happening to the severity of liver disease, this was happening more commonly in the lean patient. There is a little paradox here, but as I said, the data is little, controversial, and we can have more discussion on this in the discussion. Next slide, please. Uh, Third most important thing which I said, other than the basic disease, other than your metabolic risk factors, is the amount of alcohol. Typically, as I said, the MASL will be defined in somebody who's taking alcohol, which is in females less than 20 gram and in males less than 30 gram per day. 20 to 50 or 30 to 60 is a new entity. Now we have MAT-ALD, but we have data to say that those who are taking even the amount in within the acceptable limits, which means less than 20 gram and less than 30 gram, in comparison to those who are teetotalers, that is no amount of alcohol at all. So again, there are a lot of studies on this, and this particular meta-analysis actually showed us that those who were taking alcohol even in the safe amount or in even the acceptable amount, their their liver related outcomes were poorer and worse than in comparison to those who are not taking alcohol at all. Next slide, please. Alcohol is also a very important determinant. As I said, even a small amount of alcohol is also a very important determinant of occurrence of liver cancer in these patients. And again, this particular study had said that within the NAFLD, that what are the risk factors for developing liver cancer, other than, as I said, age, gender, and the metabolic risk factors, alcohol consumption was also an independent variable which was associated with occurrence of liver cancer. Next slide. Finally, I think one risk factor which is again very, very important and emerging as is that what are the kind of genomics that patient has with fatty liver. We know that the fatty liver disease or MASLD is related both to environmental factors, which are nothing but the metabolic risk factors, but the genetic factors are also very, very important, especially in the lean group, but in general also. So in general, there is a good data to suggest that those who have these gene variants, and the important gene variants we know are the PNPLA3, TM6SF2, MBOT, HSD17B is kind of a protective gene. So depending upon the combination of these gene variants somebody has, people have now come out with so-called the gene risk scores. So depending upon the kind of risk you have from these gene variants, your risk of having advanced liver disease, including cirrhosis, your liver cancer goes up. Now, people are now combining your clinical risk scores and your genetic risk scores together, and then trying to determine your risk of having a progressive liver disease, and all this can put you at a risk of having both cirrhosis and liver cancer. Next slide, please. Now, last maybe 5-10 minutes on about, I was also told about that how do we kind of arrest the progression of MASLD, and can we really change the natural history of MASLD? As I said, these are the various risk factors which we said and which we discussed about the natural history of MASLD. So again, these risk factors have been divided into two categories. One are known as the non-modifiable risk factors. You really can't do anything about that. For example, age, you can't do anything. Gender, you can't change. Similarly, your genes, you can't change. So ethnicity, you can't change. So these are some of the risk factors which are non-modifiable. But then there are certain modifiable risk factors which you can obviously take care, and then yes, you can arrest the progression and you can even control the disease. So amongst the modifiable risk factors are, if you look at this, are nothing but the metabolic risk factors, may it be your obesity, diabetes, hypertension, dyslipidemia, diet, and the other things. All these are modifiable. But as I said, certain factors are modifiable. There are other factors which are non-modifiable. Can we go to the next? So again, as I said, again, let's look at the modifiable risk factor. So it all boils down to your lifestyle. So lifestyle means that the control of your body weight, control of diabetes, hypertension, and your dyslipidemia, and all the metabolic risk factors. The time will not permit me to get into the details, because lifestyle interventions in MASLD is a topic by itself, and it will maybe require a full webinar to kind of develop on that. But what I'm saying is that whatever stage of MASLD the patient is detected, whether it is just MASL only fat in the liver versus whether it is NASH, NASH with fibrosis, NASH with advanced fibrosis, or even with cirrhosis, lifestyle interventions are the key in arresting the progression of this disease. And again, there's a lot of data, as I said, the time will not permit me. Next slide. But then there are large amount of studies which have actually shown us that if you control the metabolic risk factors, next slide, and especially the overweight and obesity, and this pyramid we keep seeing in most of the meetings, that depending upon that how much, what is the kind of baseline disease a patient has. For example, if you detect these patients at an early stage of just having fat in the liver, maybe just 3 to 5% of weight reduction is good enough for them to improve their hepatic steatosis. But if you detect them at a stage when they have MASH or NASH, maybe 5 to 7% of weight reduction would be required to control the inflammation and fat. But yes, if they have a fibrotic liver, I think maybe 10% of weight reduction would be required to control the ongoing fibrosis in the liver. Next slide. But then there are challenges of using lifestyle interventions in patients with fatty liver disease. Many patients are not able to achieve these targets of even losing 3%, 5%, or 10% of body weight. And even if they are able to achieve that, many people are not able to maintain that kind of body weight. So there always you have to take the help of pharmacotherapy, maybe not only to control fat in the liver, but also to control inflammation and fibrosis. And as I said, you will see around 30% of your patients may come to you at a stage when they have already progressed to F2 or F3 fibrosis, and maybe 10-15% when they have already gone to cirrhosis. So you would need the help of various drugs. I know again there are a lot of questions on the drugs, but again the time will not permit me. But I'll just tell you the 3 important guidelines which are available and what kind of drugs are recommended as a pharmacotherapy in patients with MASLD. From INAZL, our guidelines had come, last year, and we had recommended 3 drugs, which is vitamin E, Pio, which we don't really use it much in clinical practice, and the third was saroglitazar. And depending upon the kind of the evidence we had given these recommendations, whether it is with a strong recommendation or with a weak recommendation. But if you look at the guidelines from the ASLD, the next slide, that in addition to the vitamin E and Pio, and obviously the Saro is not available there, they also are recommending semaglutide, which is a GLP-1 agonist. And now, in a recent, this month only, at the ASLD, the liver meeting at San Diego, the phase 3 data of semaglutide was presented, which was the ASCEND study, which, where the weekly semaglutide was given at a dose of around 2.4 milligrams subcutaneous injectably, and this was found to be very, very effective in improving the primary endpoint of improving both the NASH resolution without worsening of fibrosis, and also improvement in fibrosis without worsening of NASH. And on that basis, this was rather on the basis of phase 2 study which was available earlier, the semaglutide was recommended by the ASLD. Next slide. The third major guideline which actually came this year is from EASL. So this EASL, if you look at rather than the other drugs, it is also recommending another drug, which is the drug called resmetirom. So resmetirom is the new kid on the block, and resmetirom was again approved by EASL based on again a phase 3 study, and which was again published in NEJM few months back. And based on that, resmetirom has now been approved by FDA for use of patients with MASLD with F2 and F3 fibrosis. Resmetirom, again, we can have discussion on this. This is a thyroid hormone beta receptor agonist, and which improves not only hepatic steatosis, but also has been found to effective in improving inflammation and fibrosis. Next slide, please. So again, I think other than the the prevention obviously is better than cure. And again, for arresting the progression, in addition to the control of metabolic risk factors and the drugs which I said, I think the control of all the metabolic risk factors, may it be diabetes, dyslipidemia, hypertension, is very, very important. We do have data on various other modalities, but again, because of time, I'm not going into details. There is data on the usage of statins, there is data on the usage of aspirin, and there are even studies on the usage of coffee, to the extent some meta-analysis which actually has shown that it can help you in preventing the progression, maybe the occurrence of fat in the liver, the progression of mast cell D or progression of fibrosis in these patients. And finally, it can also help you in reducing your risk of having liver cancer. So I think coffee is again good for liver, and in particular for fatty liver disease. Next slide, please. So, ladies and gentlemen, I would like to summarize what I said in last minutes is that mast cell is the new nomenclature for fatty liver disease. The natural history of mast cell D is dependent on various factors. Patients can be what we call them. They can be certain patients can be slow progressors, other can be fast progressor. But we also need to know that some patients can even regress also. So all this progression, fast progression, slow progression, and the regression is dependent on various factors. But the most important factors are that what is your baseline disease. So which means whether the patient, when you see the patient first, whether they are just at a stage of just having fat in the liver, or they also have associated inflammation or NASH or MASH, and how much fibrosis they already have in the liver. That will determine their natural history, and this natural history both for their hepatic outcomes and also for their extrahepatic outcomes. So other than the baseline disease, the metabolic risk factors are very, very important. Which way the metabolic risk factors are going. If the obesity is improving, dyslipidemia, hypertension, everything is improving, the disease can obviously regress. But if these factors are worsening, patient obviously they will get into progression. Other than that, even a small amount of alcohol is injurious to these patients, which means that even so-called alcohol taken within the so-called safe limit has been shown in large studies to be causing damage to these patients, and the liver related outcomes are worse in these patients. And finally, patients, those who have metabolic risk factors and also have gene variants which are responsible for steatosis, so the combination of these two will be worse, and they can actually tilt the balance towards a worse natural history in these patients. For arresting the progression, again, I think we need to control and have a good lifestyle, as I said, and many a times we would also need the help of pharmacotherapy, and depending upon the stage of the disease, I think, and the availability of the drugs, we can choose either of the drugs which are available. So thank you very much for your kind attention. Next slide, and I'll be happy to take any questions. Thank you.
I think thank you, Dr. Jain and Dr. Dhiman. We will take up the question after the second lecture. Now I'll hand over the mic to Dr. Ramesh to start the proceeding. I see Dr. Sukumar Sarin, professor, is there, and I see him on the screen. So you start the proceeding, Dr. Ramesh.
Thank you very much, Professor T.S. Chandrasekhar. It's an absolute pleasure to be here this evening. The previous lecture or talk by Dr. Ajay Duseja has set up a perfect platform for the next one. He was talking about progression of fibrosis to cirrhosis. Which are the patients who are likely to progress? How do we detect whether the patient is progressing or not? Traditionally, we've been talking about liver biopsy, but now, of course, we are talking about non-invasive tests for liver fibrosis. And this is one of the hot topics now because of the fact that it has become all the more relevant in light of a lot of findings, some of which were presented in the Liver Week, which was recently concluded. To talk on non-invasive tests for liver fibrosis, we have Dr. Shiv Sarin, my professor, my teacher, guru, role model, hepatologist for a lot of us. And sir, as usual, I feel privileged to be moderating your session. With this, I hand it over to you, Dr. Sarin.
Thank you, Dr. Chandrasekhar, and thank you, dear GN. It's a pleasure, and I enjoyed the talk by Ajay very much. Can I share my screen? Can you allow me to share slides, please?
Yes. Are you able to see the arrow like this for
Yeah,
stirring?
I can.
And you can click on that. Ankita, and can you help him also?
Sir, at the bottom, near the raise hand icon, there's a share icon as well. Can you please click over there?
Yeah, clicked.
Okay, once clicked, please select entire screen.
Okay, then
And then you can go to the presentation.
You have to go to the window, no?
No, sir, entire
Uh,
screen would be better.
Yeah, okay, you can guide him, no problem.
So can you please start sharing the PPT?
While he is sharing, I'm very glad to see almost 1,000 people have logged in and they are listening to the webinar from all over the world.
can you see
So
now
it
the
is-
screen?
Yeah,
Perfect,
very
sir.
good.
Perfect. Perfect.
Thank you, everyone, and good evening, and thanks for inviting me, Dr. TSC. I'll try and cover these two topics as Dr. Ramesh said, and both are difficult, emerging. I have no conflict. I'll try and cover first the NITs for fibrosis assessment. But why should you assess fibrosis? This landmark study, 2017, showed with F0, all-cause mortality is, let's say, 15% over a period of 10 years or so. But if the same is F4, the mortality increases 4 to 5-fold, and the liver-related mortality from 0 increases several fold. Fibrosis is a bad prognostic sign. Non-invasive ways of assessing include serum biomarkers, first, which are involved in laying down the fibrosis, the matrix, deposition, degradation, or cytokine signaling. Remember these, they will come back to you in a minute. Or indirect way, what we are generally used to is just doing platelets, AST, ALT, or fibrosis, or a combination of the two. So AST-ALT ratios not very reliable. EPRI, which now uses platelets slightly better. FIB4, AST-ALT age and platelets comes to around 0.79 to 8. And then NFS score, which is almost same. The challenge is they have low accuracy in most of our population. If FIB4 is taken, which is the Western data, if you take just liver biopsy in F3 fibrosis compared to F0, F2, F0, F2, and F3 or F4, you can see 10 to 12-year mortality is significantly high. And if you use just FIB4, not the liver biopsy, even that above 2.67 resembles very closely to mortality. So in a way, in a population setting, not individual, FIB4 is good. Dr. Sanyal came up with this Agile 3 Plus, note it, which is LSM, which is by FibroScan. I'll come to it. Platelet, AST, ALT, diabetes, sex, and age. And Agile 4, which does not include age. This is for cirrhosis. Cirrhosis does not need age, but fibrosis and its progression, you need age. And this is a test by which you rule in, not rule out fibrosis. Here, if you go to FIB4, it does not rule. It says rule in is a rule out only. But here you rule in patients. There is another very interesting test, procollagen 3. P3P is a marker. Let's say you lay down one molecule of collagen and one pro C3 is released every time. Single test is extremely helpful, 0.73. But now commercially available is ELF, Enhanced Liver Fibrosis Panel, which has Again, procollagen 3 peptide at N-terminal, hyaluronic acid and TIMP1 as I showed you. A combination of these three gives you F3, F4, very reliable. But in early fibrosis, none of them is useful. Let's see, you have a general population, 6,000 people, followed up for 13 years. Those who had an ELF above 11.3, 7.1% had liver-related outcome. Bad outcome was seen. The message is fibrosis is bad, and without biopsy, ELF can help you. And if you combine ELF and FIB4, then you are correctly predicting 88%. In my opinion, FIB4 is less reliable, is very often overestimates. I still do not think it is mature for our population. And you can use FIB5, and FIB5 is LSM plus FibroScan. So LSM by FibroScan and FIB4, which is your FIB5. So I think FibroScan or a similar fibrosis assessment is useful. Blood tests alone are not so reliable. So as I told you, the disadvantages are sometimes it is not good, none of them for F2, F3. They may be raised in non-hepatic causes, deranged in endothelial dysfunctions. So biomarkers may not be reliable in cholestasis or jaundice, and they are expensive. The advantage is they are reproducible. Same guy, same blood test, it will be reproducible and easy. Let's look at some imaging for NITs. The FibroScan, the ultrasound low frequency goes deep, and it is in a way reflected back, and the reflection is red. In RFE, where you have a horizontal or transverse propagation of waves, it measures stiffness. The advantage of this is you can put it anywhere where you like. The disadvantage of this is it's not easily read by hepatologists. Two, its reproducibility, although is as good, but sometimes range is very small. So I prefer a transient elastography using FibroScan. Here is just to read for one more for general students or so, that the time taken in milliseconds, 60 milliseconds is normal. Here you can see about 40 milliseconds. Faster the sound comes back, stiffer the liver. 8.5 means stage 2 or more fibrosis. This is fat estimation. This is controlled attenuation parameter. The sound goes, it is attenuated by fat. Anything above 220 is not good. 306, close to 40 to 50% fat in the liver. We do close to 24,000 fibroscans a year. This is our entry point for all liver patients. But FibroScan has several limitations and confounding factors. Obese, when the skin to liver is more than 2.5 centimeter, of course, ascites or heart failure, flares like high ALT, AST, or there is alcohol, cholestasis or SOLs, and high liver tissue iron content, and the patient is not properly fasting. I would say 30% of the time, FibroScan sometimes is not as reliable. 70% it is quite reliable. So Bavino also said, if the patient has LSM of more than 10, it should be repeated in fasting or complemented with fibrosis FIB4 of more than 2.67 or ELF of more than 9.8. So as I told you, FIB5 is now this plus LSM value. What you have FIB4 is age, AST, platelet, ALT, and add LSM. So the algorithm, which I have modified from a previous publication, for common understanding, the first level is the patient has diabetes, he will probably have some fibrosis above 40 years. If there are two or more metabolic risk factors, if there is steatosis on imaging, alcohol, LFTs are showing higher AST, then you will start using FIB4. If FIB4 is above 2.67, this is a high risk. Maybe a specialist should see. Also, you do a fibro. If it is above 12, certainly there is a fear of F3, F4 fibrosis. Sure enough, if FIB4 is less than 1.3, you can wait for 2-3 years and repeat it. Although many a times, believe me, people who have LSM of 8 or 7.5 also have F2 or more fibrosis. In the presence of fat, LSM values are less reliable. As an obese guy and you have LSM of 7.5, I would probably do other tests. But as per general principle, LSM between 8 to 12, maybe a biopsy, maybe an LR elastography, which is available in US. So these two groups certainly need more attention. And in this, with a high index of suspicion, and for me, platelet is most important. So when your elastography or the test by blood tests are not so reliable, you may use an MR elasto. And this paper, where about 800 patients from 8 international cohorts were studied, then F4 means there is a 4.45 kilopascal. And you will see the difference between F2 and F3 again. You cannot be so reliable, 3.14 or 3.53. But if you use the standard deviation, there is an overlap. Yes, F0 or F1, yes. F4, yes. But this you can do also by simpler tests. The advantage is sometimes the guy is very obese, so it is not confounded by liver steatosis or obesity. However, the problem is the cost. Who will read the tests? So let me summarize very briefly that NITs and assessment of liver fibrosis are reliable in predicting need for liver biopsy and provide a fibrosis continuum. Today your LSM is 10, tomorrow it is 12. It was 18 and it came to 14. So it provides you in the same individual a scale, may predict outcomes. Early fibrosis in general population, whether you use LSM or anything. ELF, it is helpful and is better than FIB4, but expensive. And LSM, I think, is as good as MRE. MRE, especially in obese and others. All these tests are less reliable, F2, F3, monitoring, although FDA is moving towards non-invasive, but I think there may be challenges. There are no etiology-specific cutoffs, let's say for autoimmune or alcohol. So I think a combination of blood tests and tracography is helpful. Now let's see, your patient has portal hypertension. But what is the relevance? The relevance is assessing subclinical portal hypertension, and I'll show you it is not 10 millimeter, it is 8 millimeter or above, which can cause hepatic decompensation. So start working early, but this is all HVPG. Here this very large study shows you patients who had an HVPG above or equal to 20 in 2 years, nearly half. Those who had 6 to less than 12, only 11% decompensed. Let's dissect it. Between 6 to 8, 9% decompensated. Between 9 and 10 millimeter, 20% decompensated. At least we believe that a pressure of 8 or above is harmful because you may get decompensation event. So early intervention, HVPG is an invasive test. Many of these have made any help. So this tells you biopsy helps, HVPG helps. There are some biomarkers, 1 Willebrand factor and more than 315%, ELF above 11, and ICG retention above or equal to 16.7, 20, and SSM more than 40. These are the current guidelines or tools for deciding. So liver biopsy has cirrhosis for A, large small nodule. So you put in a catheter into the hepatic vein through transjugular or route and inflate the balloon, and it gives you wedged pressure, or when you deflate the balloon, a free pressure between the two here millimeter. And anything about 10 is clinically significant. You don't need to do all these tests if there are varices, but in the absence, do them. So liver biopsy are invasive. So let's see the non-invasive test. Can EPRI help? Sometimes it can help you, but portal hypertension, very little data. ELF, yes, you can see that clinically significant portal hypertension, that is 10 or above. When you're above 11.1, then you can say, yes, this patient may have brand factor. I'll come to it twice. It showed that one brand factor closely reflects HVPG closely, and a reduction of 5% or more on beta blockers, that these patients are responders to beta blockers. Why? Because 1 Willebrand factor indicates endothelial activation and injury. A reduction in 1 Willebrand factor means decreased inflammation, risk of further decompensation, and liver death. We routinely do it. 1 Willebrand factor also in these combined multiple studies clearly shows you it correlates well with vascular intrahepatic vascular resistance. It gives you a high about 315, or certainly it is a HUPG above 10. Fairly that compensated advanced chronic liver disease, or in simple terms, compensated cirrhosis, if it is. Compensated when you have probably above 15, then you have a 20 kilopascals and you have low platelets, or you have kilopascals. This means this is clinically significant portal hypertension. Of course, if something is less than 5, you are okay, but from 10 and 15, it is a gray zone. Avoided between 10 and 15, but not in two groups. This means this is a group of clinically significant portal hypertension. We tried and did a large data analysis. Who should be given beta blockers? Who should not be? So in this large study, LS, HVPG, and FLIP4 were done. And an LSM about 22 was closely correlated that these patients will benefit from beta blocker therapy. I would say 22 to 25. If the patient gets an endoscopy, good. If not, and he is cirrhosis, you may do a beta blocker therapy. MR elasto, the question was specifically asked to me. I'm not going to, but just to tell you, as in the previous one, 4.7 to 4.9 means it is an advanced fibrosis. but it does not tell you response to therapy as well. Spleen stiffness is the emerging area, and while the liver stiffness gives you very good reliable indication of F1 or F4 fibrosis, spleen stiffness measures the congestion and stiffness due to the portal pressure, and it directly reflects that unless there are shunts, bypasses are there, or the patient has portal vein or splenic vein thrombosis. Let me tell you the new machines. FibroScan 630 has 100 megahertz. This 100 megahertz is one where you can do the spleen stiffness, because spleen stiffness is much above 75 kilopascals. And you can also use F3, the Accuzan S2000, probably, but most reliable is transient elastography using 630. So the simple formula is LSM above 25, portal hypertension. Splenic stiffness above 50, portal hypertension, which is significant. The other formula is to rule out less than 21. We just recently published that the Indian population, maybe a few thousand patients, up to 32, you can say this patient is normal. But to be most reliable, less than 21. So let me summarize this part. Non-invasive tests are promising in predicting presence of CSPH and excluding patients who do not need endoscopy, but they do not go hand in hand with the rise in HVPG. Can you assess response to beta blockers? And this study showed that the hemodynamic response to beta blocker, either measured by HVPG or spleen stiffness, were quite correlated. So the learning point is you can use spleen stiffness for response to carvedilol. And here you can see that although LSM also decreases, but spleen stiffness is much more. In non-responders, you do not have HEPG reduction. The liver stiffness does not, and spleen stiffness probably is unchanged. So to assess response to beta blockers, what Babino says, a decrease in LSM of more than 20%, and you should have an LSM of less than 10, or you have earlier higher, a 20% reduction to less than 20. But it is still open to questions. Spleen stiffness and primary prophylaxis, MR elasto was used, but as I told you earlier, it did not correlate with HVPG. Also, very low ability to differentiate response or no response. Well, this study very showed you that non-selective beta blocker, very small, is the only one which says non-responders versus responders. In responders, decrease responder, but I think if you see spleen stiffness, there is will decrease. So I don't think MR elasto is very sensitive for this. People have used the artificial intelligence, radiometry, they compare HVPG, then an auto machine learning develops and based HVPG. So you have this, and then you develop multiple radiomics features. I'll not go into detail. And radiomics, at least in this study, showed clearly that you can detect HEPG about 10 or about 12 or about 16 or about 20, and you are very specific and also quite sensitive. But I think if you look at generally, the positive predictive value is good, negative predictive sometimes is not very good. But yes, it is an emerging field. I'll show you some data from ILBS. We were the first in the world to use spleen stiffness 75 kilopascal probe in patients who had EHPVO, and we were able to say bleeders and non-bleeders. So EHPVO bleeders had a higher spleen stiffness than the non-bleeders. And the response to beta blockers was studied in a thesis which we haven't been able to publish, haven't submitted, in 137 patients, of which 56 were carvedilol responders, 80 were non-responders. But very interestingly, and this was presented 2 years ago, that patients who have got an SSM, which is showing a decline in the responders, but non-responders, it did not. Similarly, LSM also decreased, and it has a very good reliability. So an SSM reduction of 10 or more, that is 6.5% reduction, is a good response to beta blocker, and LSM of 5% reduction is a good response. This was Akhil's thesis. So I'll now summarize this part. Non-invasive tests are promising in predicting presence of clinically significant portal hypertension and high portal pressure. They exclude patients not needing endoscopy, but they are not reliable in predicting success of beta blocker therapy. Our data is not published, so I can't say do it, or a rebleed. And etiology-specific cutoffs in CSPH is not there, and combination of tests are better. Thank you for your kind attention.
Thank you very much, Professor Sarin. I think you have it was a brilliant talk as usual, and you have covered up most of the points that have been raised in the form of questions. I hand it over back to Professor Chandrasekhar for conducting this meeting further.
We have a solid 40 minutes now, and we listen to the two wonderful talks, first by Ajay and second by Dr. Sarin. What we have decided is, let's start with Dr. Dhiman. One question to the first speaker, the next question will be the next speaker, and we'll go by a round. The first two moderators and 4 panelists, 3 panelists, we have that. So we'll go in circles so that all of us will have a chance. Then we have around 24 questions, whether it will be able to cover all the questions so that. So let me start with Dr. Dhiman. So your comments on the thing about, I request all of you to be very brief in the question and answer too, so that we can cover 40-50 questions. Okay?
Okay. Dr. Chandrasekhar, do you want me to summarize the topic also given by the
No,
Ajay or
you want to take some expert comment or whatever you want. And I'm very glad to tell you this webinar has been attended over 1,200 delegates from all over the world. So everyone is watching us. So we want you to start with the Professor Dhiman, and we will have I told you that we'll have 2 moderators and panelists. Each one will pose question too, and we want to have expert comment also. Welcome.
Okay. Thank
Yes,
you, Dr.
Professor Dhiman.
Chandrasekhar. Yes. The talk given by Dr. Duseja was quite comprehensive. I have the list of the questions to be asked by the panelists also. So the first question that I'd like to ask, what is the best diet to follow in early chronic liver disease? And in proportion of the carbohydrates, protein, and the fat. The question is that whether the diet can halt the progression of the method in patients. So this question I will ask Dr. Anil Arora if he can respond to this question.
Yeah, thank you, Dr. Dhiman. Once you have an established cirrhosis, it will all depend on the etiology of the cirrhosis. If it was something to do with the viral hepatitis and alcoholic liver disease, then diet may not have much role in terms of subfractionation into the carbohydrate and protein component. But if the basic triggering event of cirrhosis was a metabolic associated liver disease, then you may have to restrict fat in the diet. But once you have established cirrhosis, I don't think diet will have much role. But ultimately, what you want to do is you have to supplement at least 1 to 1.5 gram of the protein. Because in any case, the synthetic machinery of the liver by the time you have end-stage liver disease will be quite fragile. So diet will have much more role in the etiology of the disease rather than once you have an established cirrhosis.
The one thing that I would like to ask you, the role of the coffee or the Mediterranean diet, that's any particular role, or you just say that they are as good as the other diet also?
I think at least the coffee has substantial evidence. In most of the international guidelines, if you take 2 to 3 drinks of the coffee, even if it is a decaffeinated coffee, it has ample amount of polyphenols, which are supposed to have not only protection in terms of the development of the liver disease in the first instance, but also it is believed that 1/3 chances are that your liver cancer may, the incidence may get attenuated. So consumption of the coffee, I think, is a big yes, even if you do not like it. It is one of the protective agents which should be strongly recommended. People may
I
not
would have
like
liked,
at least
I would have liked all. I would have liked all holding the coffee now today. So why decaffeinated coffee, Anil?
Yeah, you see the decaf. No, it doesn't matter. Earlier it was thought. In fact, Dr. Ajay would remember we used to have multiple debates: which type of coffee, what amount, how many glasses, whether it should be filtered coffee or decaffeinated coffee. But there is good literature today to show, and even if it is a decaffeinated, it is not the caffeine which is causing the giving you the advantage of prevention of the liver disease as well as prevention of HCC. It is the polyphenol which are present in the coffee beans which are important. So decaffeinated coffee, if you like, you can jolly well take it, but at least take 2 to 3 cups. Problem in India is most of the people prefer tea over coffee because of the taste. I think it's just a question of developing a taste for it.
Okay, this leads to me a very interesting. Down south will take more coffee than I think Dr. Sarin would agree with me. Ajay, is there any data available where south the kind of mass yield is less common compared to north, because we take more coffee than we can do some study on that. We can
But
take more.
But
Yes.
Dr. Chandrasekhar, if you see the burden, as in the Kerala, the Dr. Duseja has shown 48%, 50%. It is not less. It is quite high in southern state. Dr.
But
Duseja,
of all the southern state, Dr. Dhiman, Kerala drinks less coffee. I don't know about GN Ramesh. What do you say about the maximum number of coffees consumed in Tamil Nadu and the Karnataka?
The
So
type of coffee pattern of coffee intake in the south is not what is recommended actually. So we take it with milk, we take it with sugar, and I don't think we take it in the way that it is recommended with reference to liver disease as such. As far as Kerala is concerned,
recommended, Ramesh? What is the way recommended? So a lot of people, 1,000 delegates watching.
What is, yeah, that's what I was planning to come to. Doctor, I think Dr. Dhiman had mentioned about this coffee intake, but I would probably request Anil or Ajay to take up this point. What is the best form of coffee intake which is therapeutic for the liver?
I think Ajay, he only started the idea of coffee in his lecture. What is your opinion about coffee? And I like to have Sarin's opinion about coffee. I think both of you drink coffee or not? No? I think. Okay. So Ajay, what is your take on what kind of coffee?
Yes, I think this point has been well made by Dr. G.N. Ramesh. Sometimes the benefits of coffee may be counterbalanced by the sugar and the milk. So data is 3 or more cups per day, and that's predominantly what we say for the black coffee. So I think this. So that, and 3 or more.
Any data available from India, Dr. Eapan or Professor Sarin, about coffee to start with? Dr. Epan, you have done any study in Vellore that Vellore they drink a lot of coffee?
Sir, I'm not aware of data from India on this. I will go out from Sarin's comments on this, please.
I'm not aware of the data from India, but yes, all of us drink coffee. It is the polyphenols in the coffee, which is a phosphodiesterase E inhibitor, and also the thiols, which make this better. The caffeine may or may not play a very big role in that. But as of now, everyone says it should be caffeine plus this. More data is required to say decaffeinated is as good or probably not. This is my thought.
Professor Chandrasekhar, may I just come in here? So if we have an evidence which connects coffee with therapeutic benefits for the liver, are you aware of any formulation where you can always think that coffee could be made available as capsules forms for intake for patients with liver disease? Why has that not happened so
All
far?
the cytokines and everything disappears, and I never thought I would have had. I thought there were many other important topics. Coffee remains controversial. Ajay might give more data on that, but people don't know how it works. It does clear. It is anti-TNF, and you can have the same thing with curcumin. You can have same things with pentoxifylline. You can have with walnuts. They all are phosphodiesterase E inhibitors. So I think coffee is one of the phosphodiesterase inhibitors.
I think we move on to more serious topic, as Dr. Sarin said. I have a couple of questions to ask the panelists and the speakers from the questions we have received from the panelists. And the question here is, how effective GLP-1 receptor agonist and the seraglutide inhibitors in mast cell? Dr. Ajay, what is your take on the first question from the delegate?
I did mention briefly about the role of GLP-1 agonists, and the data what we have is now on semaglutide, which is a GLP-1 agonist. So initially we had this phase 2 data on what basis, as I said, the SLD had recommended in those with the type 2 diabetes and obesity semaglutide in patients with MASLD. But in the recent ASLD liver meeting, as a late breaker, the results of ASCENS study were presented. This was a phase 3 study on the usage of semaglutide, which is GLP-1 agonist, 2.4 milligrams subcutaneously weekly, and they have given this interim data, and they have reached their primary endpoint, which means the resolution of NASH without worsening of fibrosis, and even improvement in fibrosis without worsening of NASH in comparison to placebo. And this was the readout, and I'm pretty sure that now they are going to apply it to the FDA, and there is a possibility that this molecule may be approved for usage in patients with MASLD, like the resmetirom. So I think we may have this approval soon.
Thank you, Ajay. There is a very interesting question from Bhuvaneshwar. What is to Dr. Sarin, what is the most inexpensive and sensitive biomarker to assess liver fibrosis?
I would say platelets.
Okay. And that is easily available and least expensive.
The reliability of platelet count is challenged, but if it is done properly, platelets are one of the most sensitive indicators of portal hypertension. Second, of course, you can have FIB4, where platelet is pegged on by AST, ALT, and age, and then you can go on. But the cheapest, most sensitive is platelets.
I think when you look at the investigation, general investigation, it is the platelets that becomes the focus, that the person might be having the underlying the chronic liver disease, and followed by the FIB4, and in cases the fibroscan also.
Is it a marker to assess the size of the varices also? any correlation between the platelet count and the kind of variety you're going to have?
Yes, less than 150,000, you will start saying there is fibrosis, and closer to 100,000, there will be portal hypertension. Less than 100,000, definitely portal hypertension is suspected, and the risk of liver cancer increases. So less than 150 is the cutoff.
Cut off then. Any question from Professor Yeepan you want to ask? Somebody comment on to the speakers or your comment?
Yeah, no, I was just wondering which Dr. Sareen just now mentioned about the low platelet count and as a marker of portal hypertension, and correlating with the SSM and EHPVO that you said. We know that in EHPVO, thrombocytopenia is often a very marked phenomenon. I wonder, is there any link which you would like to, does that information help us understand it any better? I just want to ask you, sir.
Yeah, the HPVO, although your portal pressure seen as the HVPG may be normal, but the real portal pressure, direct puncture or intravaricial, may be 25. So I think it reflects the stage of portal hypertension and the platelet count. So in my opinion, thrombocytopenia in a EHPVO is not merely hypersplenism, it is a reflection of the degree of portal hypertension.
Can I make a point?
Yeah, please you carry on. Ramesh, you want to ask some question or comment?
No, I actually Professor Sareen has actually answered a lot of questions which are there, which you had put up. But I thought I'll pick up a couple of questions from the chat box.
So please.
First one is, many times there's a variation between ultrasonography, transient elastography, and FIB4. The results do not correlate with each other, creating a lot of confusion. So what should be done about it?
Ultrasound picks up the fat well, but fibrosis too early. Fibroscan can pick up fibrosis better, and certainly blood pick up, but none of them, the sensitivity and specificity is just about 70% or so. 30% errors are there, especially F2, F3. And I do not think we are anywhere close to use the expensive ELF. To me, one single test guiding is the platelet count. And yes, fibroscan above 20, no doubt. But fibroscan between 8 and 14 or 8 and maybe 15, I would not be very concerned. The patient loses weight, very often the fibro comes down. And yes, if there is a LSM of 10, platelet count is 110, I would do a biopsy, certainly, as a practical guide. But if platelet is 165 and a fibroscan of 12, I will wait.
So you give a lot of weightage to platelet count. Dr. Rajiv, yes. You wanted to make a point. Dr. Rajiv.
Sir, good evening. Sir and everyone, good evening. Sir, one practical difficulty we see while doing a fibroscan, if the bilirubin values and SGOT-PT values are, say, above 4 or 5, do we repeat the scan once the inflammation settles? Is there a cutoff like that, like above 4 times normal or something like that?
Yeah, fibro is least reliable in jaundiced patients because it is measuring stiffness. And if the hepatocytes are filled up with either bile or the constituents of bile, it will be it does not measure inflammation, which is high AST ALT. It is called a gray zone. So fibro values, maybe if there is a ALT AST of 80 or 100, you can reduce the fibro value in general by 2. Say it is 12, AST ALT are high, decrease it by 2 to be, but this is crude, my common stupid way of doing things.
While you are asking GNR one more question,
Thank you,
And
sir.
I asked Murugan just raised his hand. What is your comment, or you want to ask some question to both the speakers?
About non-invasive tests, there is another marker which Dr. Sareen briefly mentioned called the FIB5, but there seem to be two FIB5 literature supports. One is the one Professor Sareen mentioned, that FIB4 plus LSM. There is another FIB4 which seemed to have originated in Egypt, mainly for Hep C patients, where they looked at alkaline phosphatase, albumin, AST, ALT ratio, and platelets. They have removed age. And in Hep B and C, it seems to do a little better than FIB4 in predicting fibrosis. So is that something we should explore more, because FIB4 has a limitation for age, lower and higher age. So will FIB5 be something? I've not used it, so I wanted to know anybody is using it, especially Professor Sareen. What do you think about the FIB5?
I'm not using for FIB5, but I'm very fond of FLI, fatty liver index, which includes, to my mind, the best ratio. It has serum triglyceride, BMI, waist, circumference, and gamma GT. Whole of Korea uses FLI, and FLI above 60 is very harmful. FLI of less than 30 is okay. So fatty liver index is a very simple, large population-based thing, except, and this is used by the Korean Association. FLI is good for predicting outcomes because visceral fat is not picked up by any method except using waste.
That is interesting. Professor Sareen, one more question which has come, and this brings the question of ethnicity and where the patient comes from. From Rup Jyoti Datta, he says that in the northeast India, platelets are usually lower than the rest of the country, and also there has splenomegaly. So how do you bring in all these variations into the interpretation of these results?
A very, very important question, a very important unanswered. Today I saw someone who was from Kerala, no, Karnataka, very lean and thin person, doctor, and his fibroscan was 26 and liver fat was 145. Cap value was 1 and BMI was 23. But so the question remains that, but the waste was more. So in my mind, whichever part of the world you are, I think waist hip ratio or waist alone is more important than the BMI, and therefore FLI in my mind should be assessed much more.
While we move on to the another question, Dr. Anil Arora and Yeepan, they raised their hand. You want to make any comments or the question to the speaker?
Dr. Anil first, please.
Yeah. May I ask a question to Dr. Ajay, if you are around?
Yes, I'm around.
Ajay?
Yes, I'm there.
See, everything boils down ultimately to the first step of deposition of the fat in the liver. With passage of time, having second hit or parallel hit or multiple hits, ultimately will go on to MASH and then different stages of fibrosis. GLP-1 agonist, combination of GLP-1 plus GIP agonist and glucagon agonist, which practically will banish the fat from the liver, especially in obese people who are likely to develop this multitude of problems stemming with diabetes, hypertension. So what will be the role of current generation drug like tirzepatide or retatrutide to get rid of the basic problem rather than falling up with fat and different?
There's some issue with the voice. If I got it right, the GLP-1 agonist, if we look at the data, they predominantly work by weight reduction only. there are hardly any GLP-1 receptors in the liver. They are predominantly working as weight reduction. Rather, people are now having apprehensions about occurrence of sarcopenia and the muscle loss with GLP-1 agonist. So their major action of improving the muscle D or improving fat from the liver is by weight reduction only. But in addition, yes, they do have some anti-inflammatory or antioxidative and some other actions as well. But the action is happening by the weight reduction. This may be applicable to the other drugs, tirzepatide and the other molecules, and even the combos which are coming, GLP-1 with GIP, GLP-1 with glucagon, the all various combinations which are coming in. The action would be with weight reduction. Yes, they do have some other actions as well.
And Dr. Yepan, please.
Yeah. Actually, my question is really to ask primarily Dr. Sareen. Maybe Ajay also can give his opinion. So Ajay mentioned in his talk that now 1 in 3 Indians have fatty liver disease. So we are in the middle of it. The question is, in what time frame can we expect the pandemic to start deflecting down? Would it do it? Question number 1, realistically. And 2, would it be lifestyle interventions, or would it be the newer drugs which are expected, or both? What will make it to dip? So maybe to both of you, please.
Maybe Ajay can answer better.
So Dr. Yepan, I think we have discussed this in some of the meetings earlier. Your question is very valid. So there is a possibility the advanced liver disease or cackled or the high fibrosis related to MASLD or MASH may go up. This is my personal take on this, because over the years, all those fatty liver which have accumulated, right, because of whatever reasons we have discussed, lifestyle or whatever, I mean, some of them are gonna progress. So the patients related to or relate MASLD, cackled, or as I said, advanced fibrosis or MASH may go up. This is my thought on this, because as I said, we over all these last a decade or two, all these fatty liver patients have accumulated. Now, what is further going to change or cause regression, whether this will be the lifestyle or the drugs, I think predominantly this is going to be the lifestyle, because 70-80% of all fatty liver, whatever is there, even if you say 1 in 30% or 40% fatty liver, 70-80% are just fat, maybe very little inflammation. Only 30% have what we call MASH or F2 or beyond fibrosis, and maybe 10% would be cirrhosis. So majority of these patients, those who just have fat in the liver, I think lifestyle interventions would be the key. Yes, drugs do have a role, especially at a stage where people have gone beyond F2 and more fibrosis.
Dr. Duseja, my comment on this, Dr. Yepan, if you don't want to move and burn calories, these are the 3 drugs: GLP-1, resmetirom, or FGF21. What all they do is lipolysis. They will cause increased oxidation and reduce your weight. So what people want is don't move, don't do reduction in diet, but become better. This will not work. The only way is to have your own metabolism improve without using resmetirom, which costs about $5,500. For 30 days, you will get thin by just spending. Your wallet will become thin. So I agree, but what the new trends are, the obesity is dipping in the US, just last week's data. And in India also, I hope with all of you, with INSL, with Ajay, the national program started 3 years ago. So I hope by the end of 2030, we may have a fatty liver reduction, probably visible in one form or the other. But as of now, any drug will make 1% change. 99% will be lifestyle. 1% change because you can't afford and you can't take it lifelong.
The one
Now
comment
we are
from my
coming
side.
towards the end of the session now. We have 8 minutes to go. I just want to have a wind-up comments from the moderator, G.N. Ramesh and Professor Deeman. After that, give me 5 minutes to know more about you other than hepatology. Okay? So that 5 minutes, don't go, stay with us. Ramesh first, what is your wind-up comments on this?
So winding up comments, I think we had a brilliant talk by Professor Sareen. I think what he did mention was the importance of platelet count as a very, very inexpensive investigation to just think of patients who have significant fibrosis. He outlined the importance of all the non-invasive markers, but he did mention very specifically about 2 or 3 areas where there have been developments. Number one was I was very impressed with the fatty liver index concept. Of course, this is something that we should be using for fatty liver. He also mentioned that Agile 3 as a calculation will rule in fibrosis, whereas FIB4 rules out fibrosis. But then the gray zone still remains, and this is where we need to actually have a good algorithm. And of course, the fact that investigations like FibroScan or the SWE, these need to be used commonly, but with more specific interpretations on an algorithm, and thereby dividing or classifying these patients into groups where relevant actions can be done. Of course, there are many more points, but I think what stood out was the fact that there is a future, and this is something that in the near future we'll be using it to actually prognosticate liver disease as well as diagnosis. Thank you very much.
Thank you, Ramesh. You were really glued to the screen when Dr. Sareen was talking. What about Dr. Dhiman, your comments? I mean, your wind-up.
Yeah, I really enjoyed the talk by Dr. Duseja. It was a brilliant talk also. He emphasized on the burden at the moment, or it is around 30 to 40%. Global is the 30% also. And regarding the progression, he told us that the baseline liver disease, means the fibrosis, is the major determinant as far as the progression of this disease is concerned. If there is no fat, it takes the longer time. If there is no fibrosis, it takes the longer time to develop the end stage or the cirrhosis of the liver. And if it is already there is a fibrosis, then progression is much faster. He quoted one study. If the no fibrosis, it took almost 14 years. And if there is the fibrosis of different grades, NASH, then it takes around 7 years or so. And besides that, he also emphasized, as far as the progression of the disease is concerned, is the number of the metabolic factors that matters also. So there are so many metabolic factors, and there was a discussion also when the disease will start decreasing. Amongst the various metabolic factors, I think obesity and the diabetes, they are the two most important. As far as the diabetes is concerned, nowadays there is a pandemic also, and it is increasing also. I doubt that it will decrease by 2020 also. There are no criteria by any of the societies that these are our targets that we should achieve reduction in the obesity or the diabetes, and ultimately improvement of the reduction in the MASLD also. I think this is the one point I always say, that the NAFLD or MASLD, they are the public health problem, as we have the hepatitis C virus or the other hepatitis. Hepatitis B, you take care with the vaccine. Hepatitis C, once you have the oral drugs, then the WHO sets of the targets also. I totally agree with Dr. Sareen also. It is 99 is lifestyle modification. I think it is only the 1%. When they fail, then you have to intervene with these drugs or so.
Okay.
And another important Another important thing that Dr. Duseja said, though no amount is of alcohol is safe. I think that is a very, very important message. Somebody say for the female less than 20 or for the male less than 30 per day. I disagree with it. I think no alcohol in these patients with the method also. Then he talked about the genetic factors as well as the progression of the disease is concerned. He told that lean NASH, these genetic factors may be operating more also. And Dr. Sareen has given a very good example of the lean NASH, where the importance of the waist to the hip ratio, I think that is very important, better than the BMI also. As far as the
Yeah,
arresting progression is concerned, I am going to stop now.
okay. I think both moderators did a fantastic job. Now, last 5 minutes is my. I'm going to ask the question to all the panelists. Dr. Sareen, you are a good poet. I know that very well. Often you can you can compose poetry also. Can you just tell me a few words of poetry on liver, the one you love so much? Offhand. Oh, maybe I can.
Yeah, this is a great.
Yeah, this is not. I was. I know that you can often. I listened to you when one of the ISC meeting. You often gave a poetry on that. Maybe I'll give you 1 minute time. I'll come back to you again while you are composing the poetry. And what is the driving force? And it's all rapid fire rounds, and it should be immediate. I mean, one word answer while he is composing the poetry. See that he is just started now. What is the motivating force to Dr. Dhiman? You've been working very hard now, administrator, and you are continuing your liver work. What is the motivating force for you?
I have a habit for doing the hard work. That is the motivating force as far as myself is
Hard work
concerned.
comes with the motivating. What really motivates you so much?
I think the challenges in the life.
The challenges, you like to face the challenges, that is the motivating. Dr. Anil, you tell me the famous quotation you really look for. I mean, you always liked it very much in your life. What is the famous quotation? Or your own quotation in your life? What really?
Yeah, I think we tend to read too much into the body when we know very little about the physiological processes which are occurring. I think
But
the
that is
body
only statement. Your quotation.
Yeah,
Quotation
but
has to be something.
we hardly know anything about the body, and we tend to make too much out of it.
You know very little, but still you need to know more. Okay, I want to ask. Thank you. I want to ask Ajay. Tell me some Hindi songs related to liver. Where something where while you are composing, I mean you're remembering all these things. I will just go to Dr. Eapen. What is your quotation, famous quotation you like to listen? I mean, you really follow in your life. What is the quotation?
Okay, let me also think, sir. I'll come back to you.
No. I cannot. I have to compose poetry. I can give time. And to see the songs, I think Ajay has gone and looking into the web, I think, motivating factor. And Ramesh, what is the quotation you like while Eapen is thinking? G. and Ramesh? A famous quotation. Okay, Dr. Murugan, what really inspired you to take up hepatology as a field? Ramesh, you are telling me the quotation. I will not leave you. Okay. And already Dr. Sarin is ready composing a song. I mean, the poetry on liver. Okay, Doctor. No, I
can I say something? Everyone is, of course. I mean, you've taken all of us by surprise. But something that
what I always feel is the best way to relax yourself is just come out of your comfort zone and see that something very really interesting and intriguing you, and you start practicing on that. That's what I do. That so. So, what really inspired you to take up hepatology as a career?
Let me tell you before I forget.
Okay. Oh, you have already composed the poetry.
I am going to recite you two things.
Okay. That is the spirit.
This is from Madhushala.
Okay.
Chah mujhe. Do you understand Hindi?
No, I understand very well, but I request you to tell for the sake of the audience, because 1,230 audience there now.
I can't do it in English, but I'll say it in Hindi. चाह मुझे उस प्याले की जो दूर हथेली से प्यार. I love to have that glass of or cup of wine which is not in my hand. What you what you want in life, what you don't have. चाह मुझे उस प्याले की जो दूर हथेली से प्याला. चाह मुझे उस हाला की जो दूर अधर मुख से हाला. I like to drink things.
But you are a hepatologist, you don't want to drink.
Somebody, want to love somebody, those you cannot get it. तो चाह मुझे उस प्याले की जो दूर हथेली से प्याला. चाह मुझे उस हाला की जो दूर अधर मुख से हाला. मतवालों की जिह्वा से है नहीं निकलते श्राप कभी. Those who drink, they never curse anybody. मुझे बनाया जिसने बनी रहे वो मधुशाला. मतलब even if I am dead, I want people, my friends, to live. But this is also possible without drinking. So this is a guy, the Harivansh Rai Bachchan says, मुझे बनाया जिसने बनी रहे वो मधुशाला. But last is I will tell you about Murphy's Law. Murphy's Law says everything good in life is fattening, sweet, or illegal.
Fantastic. I think we'll give a big round of applause to Dr. Sarin. This proved himself very versatile.
Yes.
Okay,
But
I
that
just
doesn't mean
want
I
Very nice,
portray
very
that you
nice.
should do always good things. After all this, good is, you can have a good food. That's all.
Okay. And come back to Ramesh. Thank you, Dr. Sarin. Just offhand, you were able to quote this because I saw you in one of the ISG meetings when you narrated a nice poetry. I was really, surprised at the same time. I was so happy that you are versatile to know that. And Ramesh, your quotation?
My quotation rises out of people know that I usually follow paths that are unconventional and have a penchant for doing something out of the box. So I think I get driven by this situation.
That is your way of working, the quotation you like.
So, desires dictate our priorities. Priorities shape our choices. And choices determine our actions. So our desires converting into actions actually all depend upon our priorities in life.
Okay, now I want to ask all of you one important question. What function of the liver really amazes you? We start from Murugan. There are so many functions of the liver. What function really amazes you, Dr. Murugan? Say albumin synthesis, because something like that, so that the audience will come to know that. Quick.
No, I think the ability to regenerate. You know the Prometheus story, so that's fascinating.
Regenerate, but no other organ. Ajay, what is your take? What kind of liver
No, I would agree. I think the ability to regenerate and the capacity of the liver to, kind of tolerate the ongoing insults for long, and that capacity to regenerate.
Your take is to tolerate the ongoing insult. What about Anil?
I am really flummoxed by the way it handles the combination of the arterial and venous blood and forms bile. Such complex interaction being done so smoothly, unhindered for next 90 years. That is something which is really fascinating.
This is one way to glorify. To tell you about a liver function. He said about the how you handle the toxin. You said the arterial venous. Professor Sarin, when you really striking? Oh my God, this is the liver. No other organ can have that. What is you think about that? I know every function would have amazing, but they're really striking function. So maybe albumin.
Dr. Sarin has to be unmute, sir. You have to unmute.
Mute. Yeah.
Yeah, I agree with what others, but to me, a SGPT or ALT of 10 is the most beautiful thing. And if you can maintain it, there is nothing. It means it's a good system.
Okay. So maintaining that, that is a very good. Ramesh, what function really? Oh my God, this is liver.
I think there's no other organ that loves the body more than the liver. It keeps the rest of the body very clean, and not only by virtue of its regenerative capacity, but also by virtue of its filtering capacity.
Okay, Dr. Dhiman, what aspect of liver really attracted you so much? Okay, this is what.
To me, I think it is handling of the toxins and the drugs. I think it
Handling
is
of the
very
toxin. Okay, and Dr. Yeepan.
To me, it reminds me of the Creator, God's handiwork. Of course, not only the liver, the entire human body. It's amazing.
You got beyond the liver now. Okay, the creator of the liver, really, you are amazed by that. How many? Can you precisely tell all of you, how many functions does liver do? Starting from Murugan. Exactly, has anybody calculated?
In meetings, we say 300, 400, but I really don't know.
No, I want on a range. Somebody is very perfect about that. Dr. Sarin is
I'm sure
leaving, I
Professor
think.
Sarin will know.
So before,
I'm sure he will know.
what is the number of functions, Ajay?
No, again, I can't tell you the number. If you tell me, yes, obviously it performs multiple functions, but the number I'll not be able to tell you.
Actually, when I went to a school, somebody asked me, a student, tell me exactly the kidney does 2-3 functions, but how many functions the liver does? Anil, you have any idea? 357.
better you give a MCQ.
Okay, what about Dr. Dhiman?
I am asking for a MCQ. I can choose amongst the four.
300, 400, 347.
I think it is 300, at least 300.
257.
257?
Yeah.
Definitely more than that. Yeepan, what is your take?
No, I think none of us know, but it's true that in pregnancy, the placenta is the liver and the kidney for the fetus. That's amazing. So when we think of these multiple functions, and then it hands it over to the fetus, that's.
Okay. I think we have come to the end of it. I think the last question really intrigues us, that we need to know more about liver, and we have to be more specific about the liver, and there's so much we know about, and that's what the Anil said. We know so much. We think that we have done it with whatever we have read it, but it is not so. And what I learned from Barry Marshall is take the path which is less traveled by others, take the path everyone abandoned by others, take the path which very difficult, others felt it that they could not continue on that. So, and take the path which really benefits millions of people in this world. That is the reason why he took up H. pylori and traveled it, and he was I was a little humiliated to start with. After that, he proved it, and he got a Nobel Prize. 10 times his nomination was sent, and 10th time only he got a Nobel Prize. So I had a close interaction with him that really inspired. So with this note, I really thank my speakers, Dr. Sarina and Dr. Ajay did a fantastic job, and moderated by Dr. G. N. Ramesh and Dr. Dhiman, and you need any hepatologist. And I'm very glad to tell you right now, 1,240 people are watching this webinar. So that is a great message we have really passed on. I must thank Dr. Anil Arora, Murugan, Dr. Yeepan, and everyone for sparing their time. And it's a wonderful evening we had, and we discussed so much about the liver. And I must thank ACG for giving this platform. Yes, Ajay?
If you don't mind, I think the question when you asked me and I started thinking about the songs on liver.
I was waiting for it. Liver and Hindi songs.
No. I actually, I have to tell you, I really can't recall any song on liver to the extent, this is how less the importance is given to the liver. all, not even the songs or even the movies, all are on heart. Dil ke upar, you will find so many movies and this thing.
The best meeting ever had about liver, and none of us knew about including me, how many functions liver does. Okay, as a homework for all of us, and thank you very much.
Thank you. Bye bye. Thank you very much.
Thank you.
Thank you.
Bye-bye.
I enjoyed
Everyone.
Anil
Great.
and Ramesh and Nipan and Dhiman.
देख सकते
Okay, thank you.
Thank you, everyone.
Great meeting, Dr. TSC. Fantastic.
Bye.